Hello, welcome to the Sports Medicine Athletic Trainer YouTube page. Today we'll be demonstrating ACL special tests. The ACL is a key structure in the knee that resists anterior translation and rotation of the knee. ACL injuries are common among athletes. Sports involving pivoting see the highest number of injuries. Women athletes are at a higher risk to ACL injuries. Non-contact ACL injuries not attributed to sports are also possible. When assessing the ACL, the PCL should be tested first. A torn PCL can give a false positive to ACL tests. The anterior drawer test. The athlete or patient is supine with the affected knee bent and the foot flat on the table. The examiner stabilizes the lower leg by covering the toes with their hip. The examiner encircles the knee joint at the joint line with their thumbs over the anteromedial and anterolateral aspects of the knee. Then, with even pressure through each hand, the examiner jerks the proximal end of the tibia to stress the ACL. A positive sign is excessive anterior translation compared with the uninvolved leg. Slocum tests. First, testing the lateral structures. The athlete or patient is in the same position as before, except the examiner internally rotates the lower leg and foot. The examiner stabilizes the foot again and performs the same anterior jerk motion. This test assesses the integrity of the ACL, LCL, lateral joint capsule, and the IT band. A positive sign is excessive anterior translation compared bilaterally with the uninvolved leg, or excessive lateral movement indicating anterolateral rotational instability. Next, testing the medial structures. The athlete or patient is in the same position as the previous test, except the examiner laterally rotates the lower leg and foot. The examiner grasps around the joint line again and performs the same anterior jerk motion. This test assesses the integrity of the ACL, MCL, and medial joint capsule. A positive sign is excessive anterior translation compared bilaterally with the uninvolved leg, or excessive anterior rotation indicating anteromedial rotational instability. Lockman's test. The athlete or patient is supine with both legs extended. The examiner flexes the knee of the affected leg to 20 to 30 degrees of flexion and grasps the proximal tibia at the joint line with the thumb over the tibial tuberosity with one hand. The other hand is placed above the knee around the distal femur. The examiner provides an anterior jerk to the tibia. When assessing the uninvolved side, you must mirror your grip to get a true comparison. A positive sign is excessive anterior laxity compared bilaterally with the uninvolved leg. There are modifications to this test as well. You can perform a drop leg Lockman test with the affected leg hanging off the table and the foot stabilized between the examiner's knees so the examiner can grasp at the joint line. You can place your bent knee under the affected knee to assist on the field or court if you have smaller hands or if the individual has larger legs. You can also perform Lockmans in prone. The athlete or patient lies on the table with the knee off the edge. The examiner cradles the lower leg in one arm with that same hand palpating the joint line. The other hand is placed on the proximal calf complex. The examiner tells the individual to relax their leg and the examiner provides an anterior force to the proximal tibia. A positive sign is excessive anterior translation compared bilaterally with the uninvolved leg. Lely's test. Lely's test, or lever sign, is performed with the athlete or patient supine with both legs extended. The examiner lifts the affected leg and places a fist under the proximal to middle third of the lower leg. The examiner then places the other hand just proximal to the patella and provides an anterior to posterior force to the femur. A positive sign is no movement from the heel of the affected leg. Thanks for watching.